Thank you very much. Is there any questions? Yes. Go ahead, Senator Manning.
Well, thank you, Mr. Chair and co-chairs for convening this important conversation. Unfortunately, as was mentioned by CPEN and others, these trends aren't new, trends of health disparities. When we focus on disparities in health care, the suggestion is we're not providing sufficient medical attention. But as many of you have suggested, the disparities are not just in health care, the disparities are in health. And those are rooted, primarily the determinants, socioeconomic and racial. But within these divisions of access to care and quality of health, there's trajectories of disease and illness that are unprecedented in the last 5–10 years. Mr. Morales, you mentioned trends in diabetes in the Latino community. 1 in 2 Latinos are either pre-diabetic or type 2 preventable diabetes. What used to be referred to as adult onset diabetes is no longer called adult onset because we're seeing it in teenagers. So in your opinion, Mr. Morales or others, what are some of the determinants and how do we compete in public health campaigns with $100 million marketing campaigns targeting these same at-risk communities? So I'm just wondering if you can focus on what you see some of the primary causes being. They're clearly multifactorial, they're environmental, they're nutritional, they're exercise related, they're insecure communities, violence, preventing children from feeling safe going outdoors. But one of our challenges is the marketing of products that are inherently unhealthful. And I'm just curious if in your work that is a focus of prevention and building healthy communities, not just treating diseased communities.
Right. Thank you for that question, Senator Manning. Diabetes is our largest priority at Latino Coalition for Healthy California. You know, if I were my bosses, I would fire me if I wasn't addressing it because it is so large. We cannot improve Latino health. We cannot move the needle on Latino health if we do not address diabetes. And yes, the roots of diabetes are complex. And, you know, we are working across the state with partners to reduce violence so people feel safe going outside and exercising in their communities, to increase the number of parks in their communities, increase access to fresh fruits and vegetables in the schools and also in food desert communities. But, you know, we're having a really hard time where we're really hitting a wall is when we start to address the issue of, I'll just say it, sugary sweetened beverages. It's what we found, that's the unique driver. That's the source of the most calories of sugar for children. And, you know, we've seen that number of calories increase over the last 20 years. And so, you know, we need to do something. We need to get in front of this. We need to educate parents about what's going on. I know the Senator has a warning label that I think that's a good step. It's a good effort to do that. But we also I think we need to get in front of this. This is an epidemic. This is something that's kind of snuck up on us. You know, when I meet with Latinos across the state, it's something that they feel is inevitable. It's become such a normal part of our existence that when I asked my aunt 2 weeks ago, do you have diabetes? Because my grandmother had it, my grandfather had it, my aunt died from complications of diabetes, and another uncle has it. And I asked my aunt, do you have diabetes? Her answer to me was, not yet. And it just rolled off her tongue. It wasn't even a thought process. It was just an anticipation of reality. So, you know, for us, we need to figure out a way to offset that $14 million of marketing that's being spent just in California to our children especially. So
thank you. And I think related to that, well, a recent survey released in my district, Monterey, Santa Cruz, San Benito counties, the public health officers of those 3 counties worked together in a survey of communities in the Tri-County area showing that children are drinking more sugar-sweetened beverages than water in all 3 counties. And if you talk about drivers of a public health epidemic, we look at the trends. 1 in 3 children will grow up in California today to have preventable diabetes. 1 in 2 out of minority communities. So it's affecting more profoundly minority communities, but it's affecting all of our communities. And the cost will be borne by everybody. So the disaggregation of data and the correlation of data helps inform us. When you look at our state budget and the billions of dollars that we're going to be asked to pay in complex medical management, that's going to be a cost borne by every Californian, regardless of their lifestyle habits or their health or whether they have prediabetes or diabetes. We all shoulder the cost. So there's an economic determinant here as well that is unsustainable. But more important than the economics is the quality of life. Children who don't have a choice, because it's not an informed choice, are being sentenced to adulthoods of complex medical treatment, amputations, lost productive capacity, and we have to break that out of these numbers as well. So again, I just want to thank all of you for the work you're doing with your respective communities and helping to inform us, but we can't let the complexity of the problem, the fact that it is multifactorial, stand in the way of us developing strategies for prevention and health promotion, which is the best way to eliminate disparities of health care.
Yes, sir.
So thank you, Mr. Chair.
Thank you. Anyone else like to have any questions? I don't know who's first.
Go ahead, go ahead. Go ahead. I was just pointing that.
Oh, okay, all right.
Sorry.
I was trying to be respectful.
Thank you.
Please, Assembly Member.
Thank you, Mr. Chair. And first of all, I want to thank you and this committee for holding this hearing on this very important topic. And just start by noting that about 10 years ago, the state of California, we had a discussion about whether we ought to collect data with regards to race and ethnicity. For those of you who remember Proposition 54, there were some in our state who did not think that it was important to know if African Americans got sickle cell anemia at higher rates than others, if Asian Americans got hepatitis B, or if, as Senator Manning pointed out, if Latino kids get diabetes. And knowing this information has saved lives. It has also allowed us to better target our scarce budget dollars and being smarter about how we move forward with things. I want to take a moment and reference, I know Mr. Tran talked about Assemblymember Bonta's AB 176 around disaggregating data regarding our API communities. Certainly I know Senator Nguyen and I represent two facets of a very diverse API set of communities, and it's incredibly important for us to know this data. I did want to ask a question specifically around LGBT data. I want to thank Ms. Miyashita for her presentation from the Williams Institute. You talked about the limited amount of data with regards to our LGBT communities, and I was wondering first if you could just share a little bit more. We have some data, but we know there's so much more data that we'd like to capture. If you could give some examples of the sorts of data that would be helpful to obtain. And then if you could just talk about what would be the positive benefits of having this data. As you alluded to, I have introduced and I'm authoring a bill that would hopefully move forward more increased collection of data regarding our diverse LGBT communities. This is incredibly important, not just to, again, address the health and other social service needs of our diverse communities, but to ensure that, again, we're using our budget dollars as wisely, as efficiently as we can. But if you could take a moment to talk a little bit more about, again, how would this data help?
Data that we have so far in California is really limited to sexual orientation. What that leaves out is gender identity. And the reason why asking questions about gender identity and should know that some of the best measures, aren't one question. So it can be a little bit more complicated. There are best practices to this, but asking about gender identity is incredibly important to figure out who amongst us identifies as being a transgender. So for those of you that kind of are used to having the term LGBT run off and roll off your tongue, even us at the Institute, we feel that way as well. We're very cautious about when we say LGBT, because the reality is that the data on T, the transgender community, still remains fairly minimal. Having the ability to expand the G, the gender identity component of SOGI into a number of surveys has a lot of benefits. But number one is really just being able to capture who among us is identified as transgender. If California is able to add gender identity to its surveys, I mean, as I said earlier in my presentation, California will be the first state to be able to do so on a population-based survey. What that means is that we can make certain claims and we can look at that data and understand what's going on generally on a larger scale than just California. Now, there's some question about whether the findings of any California-based data could be representative of the nation, and I think that's still a question, but it would be the largest kind of population base from which we could gather that data. So it would help us to better understand the complexity and the diversity and the variation within the communities that we identify as LGBT.
Great, thank you. I just want to note two things. New York State has actually, at this moment, they are ahead of our state of California as far as the efforts that they have around data collection. So I am hopeful that our state will soon catch up. And then I wanted to just conclude by noting kids in LGBT families have poverty rates that are twice those of children in straight families. Hate crimes with regards to involving victims who were LGBT is the second most common type of hate crime, comprising of 25% of all hate crimes. And then certainly with regards to health disparities, the data that we do know shows that our LGBT families are at higher risk for cancer, mental illness, higher rates of smoking, and substance abuse, and that's what we know. And we also know that there's a lot we don't know. So again, I want to thank you for your work and hope to continue this conversation, colleagues, on this topic.
Senator Nguyen.
On that note, what I wanted to ask is, when you go forward data collecting, especially the LGBT community, one thing that I've seen, or at least in the areas that I represent, or in Orange County back then, is that depending on the community, it's very difficult to know if they are LGBT or not, because there is still a cultural that is not, I mean, it's very difficult for a lot of the communities, especially the minorities community, given mainly really for my community is really, well, in my district, the Vietnamese American community is very difficult to try to, for one person to come out and say, I'm proud of it, I want you to know. It's still not culturally acceptable. And so I just want to make sure that when we do go forward trying to collect these data, is that we do protect the confidentiality of it so that people want to give us that data, because ultimately for us as governments, we want to be helpful. We want to help, but having data, but lack of data because we didn't have enough pool also hurts us, because it becomes too specific and it only affects too small of a group that we need a larger number of volumes of individuals to collect that data from. And so, you know, please make sure that whatever we do in terms of data collecting, and I know that there is a lot of confidentiality, especially in healthcare issues, but in anything else, is that, you know, it is, the goal of data collecting is to make sure that we get enough data.
I believe Assemblymember, you had a follow-up comment or question?
Just a follow-up comment. Thank you, Mr. Chair. I just wanted to respond to the Senator's questions. I think what many within, among policymakers who are interested in collecting more of this data with sensitivity to the issues that you've raised, the hope is that this data would be, first of all, collected voluntarily, so no one would be forced to provide information about their background, and then the data would be aggregated in such a way as to protect the privacy of individuals who provide that data. So those are two elements that are, I guess, part of the policy contours of how we think about this data collection.
Thank you. Anyone else have any comments, questions? Yes, Assemblymember Ridley Thomas.
Thank you, Mr. Chairman. It's a pleasure to join you all today. I came in a few moments late, but I'm interested in hearing about or discussing, and maybe with subsequent panels, about I think you all were talking about outcomes, and that's what I heard Senator Monty mention. But a part of the challenge that I'm interested in this dialogue, and appreciate our chairs for having this discussion, is about providers. and how we make sure that we have workforce pathways for providers, how we create an environment of California that is inviting of a diverse array of providers, particularly in the chronically underinsured and communities, and those that are newly insured that have yet to build a sufficient health care IQ, personally and in community, to receive care. Again, forgive me if you've already spoken to it in one way or another, but if anyone would like to talk about providers and a part of that challenge, because there's some things that have changed in consumption patterns and the like that clearly affect outcomes, and it's exacerbated when you already have inherent disparities. But in a medically underserved area, what about our providers? What about our pathways to for healthcare professionals? What about our training programs? What about gender and ethnic diversity in that conversation?
I can start with the conversation. One of our recommendations is absolutely that this information would also help agencies, plans providers look at how do we make sure that our provider workforce meets the cultural and linguistic needs of our communities, that it is ultimately reflected in the population that they're serving. A couple of recent efforts have expanded. So data collection right now is done through the medical board on doctors and dentists. Recent legislation expanded that to some of the allied health professions like physicians assistants, psychiatric techs, and nurses as well. But again, more also needs to be done. There's not, again, a sort of systematic way of identifying, where the providers are, what the demographic breakdown is of providers. And I think having additional data would help us, but we also need to move forward efforts as well. There's a couple of other ways. The ACA provides for sort of additional funding to provide non-traditional healthcare providers like community health workers to bring those individuals more into the workforce, because these are also individuals who have a much more connection to communities of color and are able to meet some of those cultural and linguistic needs. And then also through the medical health homes is, again, expanding sort of the breadth of providers that can then provide various different aspects of care to individuals, and particularly among communities of color or populations that maybe haven't traditionally been served by the community.
Can I just add something as well? We also need to look at the barriers that might exist that keep some of our population from being able to access some of these jobs within the healthcare system. I know that we're part of the Alliance for Boys and Men of Color, and there was a bill that we were supporting last year. I'm having a birthday tomorrow, so I'm having senior moments now. I can't remember exactly the number. But what it was home care workers. People go through and they get trained to be a home care worker, but in the end they can't get licensed because of 10 seconds of bad misjudgment that happened 20 years ago. And that's a pathway that helps people. You start at the home health care assistant, then maybe you move up to nurse, registered nurse, who knows where you end up. But there are barriers that still exist that we need to address like that as well.
I think one of the areas that Senator Manning touched on was the intersectionality of all the issues. I think an area that is particularly workforce development is the need for career technical education on a secondary education level to actually encourage students and young people to go into these healthcare professions. What we've seen in the API community is that there's not a lack of Chinese and Taiwanese doctors that are available here in California, right? The vast majority, or not vast majority, but there's significant populations. But you'll see in more rural communities like Fresno, Merced, Stanislaus County, in those areas, that's where you see the significant lack of individuals that are entering those types of professional trades. So career technical education on the secondary level to find those intersectionalities is important.
Last question, Mr. Chairman, with your indulgence.
I believe Senator Manning had a response, and we'll go to you, Senator Manning, for just a response, and we'll go to you.
Just on this issue that you raised on kind of workforce expansion, the chair's been a champion for trying to expand workforce linked to broader access in traditionally underserved communities. And I just wanted to mention along the line of your question, in our Budget Sub 3 committee hearing last week, the administration has included in the budget proposal that we're reviewing right now an increase in funding for the Song Brown resident primary care providers resident loan repayment, and the criteria for that is to incentivize medical students to pursue residencies in underserved communities. The data shows if you do your residency in an underserved community, you're more likely to stay and practice serving that same community. So it's, in my view, still an insufficient amount. There should be loan repayment for all students willing to serve in primary care and underserved communities, but at least it addresses that in this year's budget, expands it. So I think just to mention that, this is an informational hearing, but as our budget moves forward, I think that's a component worthy of support. Thank you, Mr. Chair.
Thank you. I believe Assemblymember Ridley Thomas had a comment, question?
Yeah, that's exactly right, Mr. Chairman. The other part that as community health advocates, I believe all of you are, is to help us and pay attention to yourselves how we create an environment that is inviting for providers. Because if it's hard to do business in California, if it's hard to be engaged in the practice of care and the delivery of care, it will be harder to get underrepresented communities. It'll be more restrictive. So there'll be a number of topics that come up that are general business conversation topics, and then they get into healthcare where it helps when you have already done the work and you've been in conversation with our offices about what it means to really get those pipelines going. I know about the Song Brown program, and we invested in it last year, and I'm glad that the governor has shown a commitment to investing in it further this year. And career technical education. He has a lot of money in for workforce anyway. I think it's unallocated increase in investments in workforce, which will benefit all of our districts, as will the four-year bachelor's programs. It's a healthcare program in my assembly district at West LA College. This is going to be a part of the pilot program for the four-year bachelor's out of community colleges. But just thinking about those general topics about operating a business and a business that's involved in healthcare, your input on that as we go along in the legislative and budgetary process will be extremely helpful. Thank you, Mr. Chairman.
Thank you. I believe Senator Pan had a question or comment.
Thank you, Senator Nunez. Actually, I wanted to follow up on Assemblymember Ridley Thomas's point because I think it's a very important one. When we look at the workforce pipeline, right, there's the issue about the diversity of the applicants, the admissions, and it's right, I think as Senator Monty said, it is correct that people who do residency, but the caveat to that is they have to actually have a practice opportunity. And one of the challenges we have run into is that we've seen networks of physicians and other health providers, but particularly physicians who maybe, I've heard from African-American physicians, I've heard from API physicians where they are trying to provide culturally specific services, but they're finding themselves boxed out of networks, right? Because they're actually taking care of a sicker population. They're taking care of us, our diverse populations that, unfortunately, if they're more disadvantaged, tend to be sicker, and they don't quite look as good as the quality measures. They may actually spend more resources because they actually have in-place interpreter, not interpreters, but they actually speak the language, and so forth, and they have found themselves having some challenges getting into networks. I've heard this in LA, I've heard this in some other communities as well, and I think we just have to be sensitive to that, that when people, as we're trying to recruit people who are providing services to healthcare services to different diverse populations, that they don't find themselves essentially boxed out. Because if you don't have a health plan, your Medi-Cal plan isn't willing to contract with you because their managed care plan decided they don't want to contract with you. It's going to be a little hard to keep your practice going, right? And that is an issue I have heard from some physicians and physician networks, particularly those that are serving diverse populations. And so I think we need to be aware of that and pay attention to that on the Medi-Cal side and also covered California and so forth.
Thank you. Seeing no other questions, I have a comment I'd like to make, and then I think it'll lead to a question. First of all, I'd like to take the opportunity for all of you who came up this afternoon to testify on behalf of the various groups you represent. Sorry to see that one of the young lady had to leave, assuming she had will get to her medical appointment. Yes, I agree that we need to look at data. Data is extremely important, whether it's data in the Department of Managed Healthcare, data at DHCS, Department of Health. And yes, it's very important that we have disaggregated data, especially amongst the API community, to look at the different subgroups. And very important how we collect the data, but it's also what do we do with the data? And more importantly, and these are the questions I'm going to ask the administration, is where do we house the data and who is responsible for that data, okay? We have a lot of problems dealing with vulnerable communities, distribution problem, lack of diversity among our workforce. We need to make sure that there's a diverse workforce that's culturally sensitive to those particular communities and unique to those particular communities, and get more providers in there. Another part of it is the rates, increasing the rates to make sure that we get providers to take these patients, the most vulnerable population. But I think what we now need to start looking at, and this is the question I'm going to pose to you and the challenge I'm going to pose to you, yes, that needs to get done. That's on the responsibility of the legislature to do it. But I think we now have to look at changing the culture of healthcare amongst this population. Because most of these individuals have never been insured before. They don't know how to utilize the system, and they don't know how properly to get preventative care and ongoing care. The Latino population, for example, most Latinos will wait till the absolute last minute. They don't have access to care, they couldn't afford it. Oh, and by the way, I'm completely supportive of health care for all. So what do? When it becomes to the point where it's, beyond the point of no return, they end up in the emergency room, the most expensive type of care that we possibly have. Or they self-medicate, especially within the Latino community. They go to Tijuana, they get their medications, they go to the pharmacy, they just kind of self-medicate. But what we have to do is change the culture of those in that population to teach them how to use the healthcare system. You go on a regular basis, you keep your blood sugar under control, you do your A1C, you do your high blood pressure check, you do your prostate, examination, is to change the culture. So the question I have for you and the challenge is, how do you as organizations now reach out to the community to change that culture now that government is implementing this historical act? It's one thing to have access or have a health card. Another thing, you need the access, which we'll work on, but how do you get them to utilize it? So the question is, it's an open question and a challenge.
Okay. Because you have your program.
Well, I think with the passage of the ACA and the Medicaid expansion, Medi-Cal expansion in California, what we're seeing is that there's been a huge disruption to a system that wasn't adequately serving all of the population. It was a system that was designed for a certain segment of the population. And so now that we have all of these new folks coming in, it's exactly what you're saying. Many do not know how to use the system, but then also on the provider side, I think there needs to be some training on that side too. We need to find out, one, we need to go out and do some education, and we have written a proposal. Sarah will probably talk more about this, about how we go out and actually educate people who've never had insurance before on how to use insurance. So we're on that track too. But then we also need to make sure that we're collecting evaluation data, because if they learn and they still don't use it, what's the cause? So we need to, it's not just a one-shot deal. We know, I know Kaiser did a study. They were trying to reduce costs. So they looked at their highest cost center at this one area was the ER. And they saw that there were these people that kept coming in with unmanaged diabetes. And every time they'd come in, they'd end up in the hospital for about a week while they got stabilized and observed. And what they found was that it wasn't that these people didn't know how to medically manage their disease, but it was that life was getting in the way, and there were all these other things that were getting in the way. And so what Kaiser did is they actually they provided them with social workers that would come out and visit with them once a month and connect them to other resources. So I think this issue of use It's a complicated one, and it's one that's going to have to be iterative, where we're going to have to evaluate on both sides, not just the providers on what's working for them, but also on the consumers and what's working for them.
And I agree, we have a strained system, especially with 1/3 of the population now in Medi-Cal, and to me, that's the population that has the greatest need and most of the problems. So I think it needs to be a parallel track of, making sure that network is robust or, efficient and sufficient, and at the same time, educating the population on how to not necessarily use the health insurance, but how to access the health wellness and how to access health care in this. Is there any other thoughts or in what you guys are doing as organizations?